Hello, my name is Jared Pinkham, and today we'll be discussing cytomegalovirus and its impact on hearing and hearing loss. Specifically, we're going to be talking about congenital CMV. And if you see CMV throughout the presentation, that's just the abbreviation for cytomegalovirus. So before we get into it, we want to discuss and address some of our learning outcomes. So what are the anatomical structures that are affected by CMV? What are those key players? What is CMV and how is it contracted? What is the diagnosis and treatment of CMV currently, and how CMV affects hearing loss in the inner ear? So before we jump into CMV, let's talk about some inner ear anatomy, clarify some of those key players. So the inner ear houses the cochlea, and we're going to talk about some gestational age because this infection mainly affects children in utero. So at 21 gestational weeks age, the cochlea divides and completes that kind of 2.5 turns, and then it divides into 3 tubular sections: the scala media, scala tympani, and the scala vestibuli. The scala tympani and vestibuli contain the perilymph, which is just that inner ear fluid that signals the hair cells. This is high in sodium and low in potassium. So on the lateral portion of the cochlea duct is the stria vascularis, and we'll have some images on the next slide to kind of clarify all this. But that is made up of 3 epithelial cell walls, mainly the marginal cells. And these are important for the transportation and recycling of potassium ions. So this is kind of like the second time I mentioned that. So why is potassium so important? As we know, with most action potentials in our body, potassium is a positively charged ion and is extremely important for that action potential and firing. Same thing with our middle ear, or inner ear, sorry. It's the main ion for firing the endocochlear potential. So if we don't have enough potassium, the inner ear cannot fire and send those signals. So again, this is just some imaging that can better help define those anatomical structures. So we have the tubular sections, the scala vestibuli, scala tympani, the scala media, kind of a zoomed in portion of the scala media. And we can see that we have our organ of Corti, the tectorial membrane. And over here, we see this little SV. That stands for our stria vascularis, that cell wall. And then we have this animated version, which is a little bit easier to see. And we can see how those marginal cells are lined up. It's pretty medial. So, and then over here, we have our organ of Corti. That perilymph comes through, agitates those hair cells, sends information through them, sends it to the auditory nerve. So now we will move on to CMV. What is CMV? Cytomegalovirus. It is the most frequently transmitted intrauterine infections. It is part of the herpes family. And as we know with other herpes, the general herpes 1, 80% of the population has it. Herpes is very easily spreadable. Same thing with CMV. It is spread through saliva, blood, urine, breast milk, cervical secretions, or semen. It is most commonly transmitted through children to older adults because they're most likely to have it, and they can, they spit on toys, sneeze, don't cover their mouths. Mainly that's how it's transmitted. So once a person is infected, the virus enters a latent stage. So most people who have CMV are asymptomatic, especially older adults who have stronger immune systems. So you watching this video may have CMV, you may not even know because you're asymptomatic. So as I said earlier, it can be transmitted in utero through amniotic fluid. And CMV is not a part of the newborn screening procedure. So this is a big issue because, again, most women who do have it are asymptomatic, don't know, and then they get pregnant and transfer it through amniotic fluid with no idea. So CMV in the inner ear. So these are some images from mice and their inner ears, which is very similar to humans, which is lucky for us. But as you can see, these little red portions, that is a cytomegalovirus. They dyed it with some iodine to make it red so that we could see it in the imaging. And as you can see, I mean, it's kind of hard to see, but trust me, that this is on that lateral portion of our cochlear duct in the scala media, which is where that epithelial wall is, or that stria vascularis. And so as we can see, it's infecting that marginal cell wall right there, which is very important for what? Potassium production. So when those cells get infected, they're unable to recycle the potassium, unable to produce that potassium. Then we do not have enough potassium in our system to signal that fire in the endocochlear potential. which is why it affects hearing and is considered a sensorineural hearing loss. So prevalence of CMV, how many people have this? Is this actually important? So 40,000 women contract CMV annually, not a huge number, especially compared to other herpes families, but still not great. Now this one is pretty jarring. 1 out of every 200 babies are born with CMV. That's a pretty high number. However, 85 to 90% of these newborns who are born with CMV are asymptomatic. So they're coming out with no symptoms, we're not screening for it. And what happens most times is as the child grows up, the CMV exits that latent stage and symptoms start to occur. So 1 out of 5 babies born with CMV will experience these long-term health complications, such as hearing loss. Other forms are blindness. That's another common one with CMV. So we know that these children are coming out, they don't have symptoms. If it exits that latent stage, say around 3 months, they've already passed their ABR. That means they're going up until about a year until people, their parents, family are realizing that they don't have access to language or sound. So characters of congenital CMV induce hearing loss. So they're born with or shortly after birth develop a hearing loss. They can come out with a mild to moderate, or they can pass that ABR and not be referred. This is an inner ear pathology, as we mentioned before. It's a sensory neural hearing loss. So if you see that baby has a sensory neural hearing loss, it might be indication of CMV. And most importantly, this is a progressive hearing loss. A baby who is born with the sensory neural hearing loss at birth, it could be at a mild to moderate and then progress to severe or profound. Or they could have perfectly normal hearing at birth and be within typical limits. And as they age, it gets worse. So some other symptoms to look out for that are not specific to the ear is a rash, jaundice, which is yellowing of the skin or white in the eyes, microcephaly, which is kind of a tinier head, low birth weight, enlarged liver or spleen, history of seizures, or retinitis, which is a damaged eye retina. So when you see a parent, say you have a child who's about a year old, they're expected to have, a hearing loss, the child's not hearing great, you could ask the parents if they have a history of any of these symptoms, and that can give you a better idea if they have CMV. So diagnosis, how is it diagnosed? Despite it being one of the most frequently transmitted diseases or infections, it goes very underdiagnosed. As we said, 85 to 90% of those children are asymptomatic, so they're not getting any type of screening for it. So previously, we diagnosed it with doing tissue cultures of urine and saliva. This was not great because it's very labor and resource intensive. It's very expensive to do this. And it's also not the most pleasurable procedure for patients to get tissue cultures. But now we are able to use polymerase chain reaction PCR technology, which is taken from dried blood samples. We even now have real-time PCR testing, which can be done through saliva or mucus. So treatment, how is CMV treated? Currently, the best method for treating CMV is through antiviral therapies. The Collaborative Antiviral Study Group, CASG, looked at 109 infants in a study who were CMV positive. And for the first weeks, they received an antiviral drug, valganciclovir. Over 6 weeks, they took 16 milligrams twice daily. The study monitored these children's hearing levels at 6 months, 12 months, and 24 months. What they found was that hearing function did not improve after 6 months, but after about a year or 12 months to 24 months, it did improve and maintained up until 24 months. So what they also found was that cognitive development, especially in language, improved not only just at 12 months, but also at 24 months. So that was pretty good to see because we want to see that, that cognitive development improving as a child ages. So how do we know what CMV is? What does it look like on an audiogram? And also, how is it progressive? I've been saying that it's progressive, but we haven't really seen that. So this case, we're going to look at 2 case studies from the Teaching Hospital of Harvard Medical School. Thank you guys so much for providing this. So this first case looks at a patient who had TMV before antiviral treatment was available. So we can see at age months, this is their first ABR. Their right ear, pretty normal, but a little low for a child. Their left ear in that moderate to severe area. And then we can see at 17 months, both hearing is starting to decrease together. So at 27 months, so about after 2 years, we can see that that right ear is dropping drastically, especially in those higher frequencies, and that left ear is completely not getting any a majority of sound. And at 2.5 years, we had a profound bilateral hearing loss. So going back, we had at 5 months, relatively good hearing in the right ear, not so great hearing in the right ear or in the left ear. And then now we have completely bilateral profound hearing loss. So over 2 years, this can really affect hearing. So now we're gonna look at ABRs and audiograms with antiviral treatment. So here we have the right ear, left ear, not great in that kind of moderate area. But we can see after starting antivirals after 2 weeks old, that left ear improves a lot. Right ear still not so great, but the left ear has improved a lot. We can see that that left ear continues to improve. Right ear is still not doing great in those higher frequencies, but isn't terrible. Now we can see at age 3, unfortunately, that left ear does drop off. The right ear is still pretty good. So then they went in for a second round of antiviral treatment. So we can see that the hearing doesn't really improve by much. It does about 5 dB, 10 dB in between testings, but we can see that it's kind of stabilized, which is really good, what we want to see. We don't want to see it getting worse. So, and this was their last audiogram that they looked at 5 years, and we can see that it's pretty much stabilized from those last 2 audiograms. So antiviral treatments aren't perfect, but it's definitely better and preserves some of that hearing, especially when we're looking compared to that first case. You know, there are other factors that go into why that patient may have had profound hearing loss, but we can see that definitely the antiviral treatments must have helped. So to end it off, why as audiologists do we care about this? Why do we need to know this? It is the leading cause of sensorineural hearing loss. That's actually kind of why I wanted to investigate this. I did a quick little Google search, saw that, and wanted to dissect it even more. So some ways that we can go around that, get around this, make sure that it's not affecting so many people, is having and instating a universal CMV screening. This was proposed by ASHA. Also, the CDC mentioned that they would love to make this more of a requirement. 90% of patients are asymptomatic. So we have patients who are born, they leave the hospital with no symptoms, we're not testing them. And over the next couple of years, they could have some serious implications because we're unaware. And these last 2 points kind of go hand in hand. So it's a progressive hearing loss. So as we saw in that first case study, over 2 years, that hearing dropped drastically. So early intervention is critical. In that second case, we saw that antiviral medication started after 2 weeks. And so getting that started pretty quickly is extremely important because this is extremely critical time for language development. And so we want to make sure whatever language they are using, they have full access to. That is my presentation. These are my references. If you have any comments or questions, please leave them down below and I will try to respond to them as quickly as possible. Thank you so much.